This video is about providing family-centered care, and we will focus on a series of 9 best practices for providing health care to children and youth with disabilities. Family members, guardians, and caregivers often play a critical role as members of a child's health care team when the child has a disability and has limited communication skills or is too young to effectively advocate for what he or she needs or desires. In this video, you will hear the perspectives of several parents regarding family-centered care.
Hi, my name is Paula Conley. I am the mother of a now 25-year-old young adult. He had lots of medical challenges when he was younger.
Well, hi, I'm Sarah Turnbull, and I am mom to 2 boys and a little girl named Stella. And my daughter Stella was born and at 1 month was diagnosed with spinal muscular atrophy.
I'm Kathleen Kingman, and I'm the parent of 4 wonderful children. My oldest daughter is 15, and she's on the autism spectrum.
Best practice number 1, help parents not feel overwhelmed. It is crucial to help parents cope with feeling overwhelmed when learning about their child's disability. It is helpful for the healthcare team to be an advocate for the family and child. It is also important to take the extra time needed to address their unique needs and questions.
Aaron's early years seemed like just a swirl of medical appointments. We saw so many specialists. I constantly heard that comments such as, "We know this is a syndrome, we just don't know what the syndrome was like." So of course we went through all of that testing to eliminate things. The scary part for me as a mom was the worry, what if a medical crisis happens and we just don't know enough to be able to manage that medical crisis.
When you're first navigating the system, you're new to a disease, you're just trying to wade through it all, and the more help that can be provided and followed up on, that care coordination piece is absolutely essential to that family because oftentimes they don't know what questions to ask.
Best practice number 2, it takes a village. Care coordination is critical for the patient's safety and quality of care and for providing support to the family or caregiver.
Care coordination is so key to just the quality of care that she receives. Oftentimes, we have found that there can be a breakdown in communication if all the players aren't on board. And it's really tough when parents go home from the hospital because now it's all in their court to take care of that child. And so it's really helpful when care coordination is there to make sure that, they're all lined up with an OT, a PT, a speech therapist, without the parents having to completely navigate that system on their own. We have actually worked with over 10 departments at the university because of the complexity of my child's needs, and it's very important when that child comes in to make sure that all the important players are involved. If they're coming into the PICU and respiratory is the key thing that they need to make sure that pulmonary is called right away, that they aren't just kind of lingering in the background. I think one of the things that has really helped to streamline my daughter's care is just that it's documented the most important things that need to be followed when she comes in, so that every time we aren't recreating the wheel of what needs to be done, because that's very frustrating to have to fight something every single time that your child comes into the hospital. Let's face it, we don't always know everything about every single disease. So if it's something that is outside of your realm, it's okay to tell a parent, I don't know, but I'm either going to find out or I'd like to, do a referral elsewhere for someone that can help you.
Best practice number 3, communication is key. Family members and caregivers are often key to understanding the issues of patients with communication problems. It is important to fully engage both the family and the patient, even when the patient is young or has significant communication limitations.
The best approach for healthcare providers is to meet every patient and their parent or caregiver as a new opportunity to get to know two or more individuals and not make any assumptions on who they should be speaking to, who they should be directing questions to. Both the patient and the parent or caregiver have perspectives that need to be taken into consideration.
One of the things about my daughter is that she is nonverbal. Due to her muscle weakness, she cannot speak. She can use limited uh-huhs and uh-uhs, and a lot of nonverbals with her eyes. And one thing that is really important is to not only talk to me as the parent, but also to her.
I think the things that I appreciate most about the doctors that we see is that they recognize that he is not a verbal communicator, and you wouldn't be able to have a conversation with him. But I still appreciate the fact that they come in the room with that, using those strategies that tells me that they believe that Aaron understands, and addressing him as well as me, asking him how his day is going. Ask me about his communication. I don't expect you to be an expert on every output device or every sign, but just say, how does Aaron communicate? What does that look like? What are some things that I can do?
That's very important to make sure that the child is involved in those decisions instead of just doing something, explaining how that would better her life. If there's an option to be giving her those options are very important, especially as she gets older, even if she is nonverbal.
I spend a lot of time with Aaron just telling him, this is what's going to happen. We're going to listen to your heart. Say we're going to pull up the shirt. Just little things like that. I think it contributes to Aaron's overall ability to be more comfortable with you. We're not doing things to him, but we're doing things with him. As Aaron is aged, I still have to play a major role as his caregiver, as sort of the reporter of symptoms. I appreciate when I send you things or I email you something prior to the appointment. Please take the time to read that. Be okay to say, hey, I wasn't able to read through all the information you sent me, but I'm going to do it, and can you and I talk, maybe a phone call or whatever. I also appreciate being asked if there's anything I want to address without Aaron in the room. Can a staff person take him down the hall, or maybe do we have to schedule a call, or could we email?
Best practice number 4, all in the family. Make sure that family members and caregivers feel that they are respected and listened to as members of the child's treatment team.
It's really important to listen to parents and to be a team. To us, she's our life and are doing everything possible to help her. So we really appreciate it when physicians do listen and truly care about a best outcome for her. I think it's really important for the staff to be open to the parents that bring in information. These parents from diagnosis time have been researching this disease day in and day out I think together we can have really good outcomes.
And it's always good when a doctor will say, I hear you, this isn't working. Let's figure out what else we could do, how this could look differently. And I think that's one of the key things that I look. And then that really truly listening, not somebody that says and continues to do things the way they plan to do it.
Best practice number 5, get real. Health providers should recognize the impact of specific treatment recommendations on the lives and daily routines of patients and families.
I also have always appreciated those doctors who recognize that disability not only impacts the patient, but it impacts the family. And asking me, how is everyone doing? Aaron's pediatrician knew enough to ask about whether or not I was connected to respite, whether or not I needed help, was there anything I felt like we needed that maybe we weren't getting. When Aaron was younger, I was a single mom for a really long time, so I was raising 4 kids on my own, and someone took the time to say, hey, are you okay? Are you sleeping? Are these things happening? Because Erin didn't always sleep through the night.
You know, we've learned very specific things that do and don't work for her, and it can be devastating if things aren't followed. For example, in the past, I know we've had some things that have slipped through where doctors were used to following one particular protocol, but it wasn't the protocol for this population of children. And we've almost lost her, actually.
I think I also appreciated doctors who took the time to think about the impact certain procedures had as a family. I remember once having a really great conversation about Erin's tube feedings. I was advocating that we not do continual drip feedings because I felt the kids at school were a little afraid of Erin because of this. We were trying to move into caregiving situations so I could go back to work, and the feeding tube was a problem. So having that conversation and then working with me till we eventually were able to roll Erin's tube feedings into typically 3 feedings a day. Those kinds of things were helpful.
Best practice number 6, cope with anxiety. All patients have a certain level of worry about going to the doctor. It is critical for quality care to take steps that help patients reduce their fears and stress levels, especially for children with communication difficulties, intellectual disabilities, or developmental disabilities.
You know, if it's something scary, make sure that you're comforting her so that she's not fearful the next time she comes in, that she understands what's going to be happening, and if there's something that perhaps shouldn't be said in front of the child, to make sure it's not said in front of the child. Because I think oftentimes it's very easy to forget that she's 100% cognitive, she understands everything you're saying.
But where we run into trouble often is when you're actually in the exam room and you're either waiting for the healthcare provider, or the healthcare provider is talking to the parent or caregiver a lot, and then throw in fluorescent lighting and background noise. Maybe somebody is vacuuming down the hallway, or even construction happening outside the building comes in a much more powerful, sort of distorted way that can really be too much for the kid on the autism spectrum. You can prevent a lot of anxiety. Keeping kids occupied, I would definitely suggest having a chalkboard or a dry erase board or Etch-a-Sketch or hand fidgets, things like that. Waiting rooms certainly can have books and videos, and sometimes they have even a Nintendo DS and that kind of thing to keep kids occupied. Waiting can be hard.
Best practice number 7, respond to special needs. Children and youth with disabilities, especially those with problems on the autism spectrum, often perceive and relate to the environment in ways that are not typical of the general population. It's important not to make assumptions based only on a specific diagnosis, because each child is unique. Observing and accommodating the child's unique responses to the environment and their communication styles will greatly increase the likelihood of achieving successful health outcomes.
I think as healthcare providers, the best people can do is really be alert and make keen observations and continue to really focus on that unique individual child and see what might motivate them. Healthcare providers need to constantly be evaluating that child and trying different things to reach that child. As healthcare providers, you really want to be on your toes and be constantly thinking about who they are as an individual and how that you might motivate them. And you just have to kind of try different things to get their attention and to reach them. Writing on a chalkboard or a dry erase marker can help a lot of children who are very visually oriented, and having a picture or a word to focus their attention can be very helpful. Other children might just focus in on what you're saying. keep a child comfortable, but not be so all engrossing that you've lost them. If you have a television on in the exam room or a Nintendo DS, you're going to probably lose the chance to speak directly to the child and have their attention. It can be really hard for kids on the autism spectrum to go back and forth with their attention. So I would avoid that. Children on the autism spectrum can just present like any other child. It really can be an invisible disability. And so it's easy to fall into the trap of comparing them to their typical peers and evaluating them as you would any other child. Like a child on the autism spectrum may have a very different threshold for pain. And for instance, if you're asking a child on the autism spectrum to rate their pain 1 to 10, they might say that their pain is a level 5 and not seem very upset about it. But that same injury could cause a typical peer to be writhing on the floor, screaming out in pain. And I know this from personal experience because my daughter, when she was about 9, had been complaining a little bit about a neck pain and holding her head funny. But when we brought her into the healthcare provider for the first time, they assumed that it was something pretty minor, like muscle pain, and sent us home. A week later, we brought her back because she just didn't seem right. And when they finally x-rayed it, it turned out she had dislocated vertebrae in her neck and needed to be taken to orthopedic neurosurgery. With children on the autism spectrum, one thing we really need to keep in mind is that each one is an individual and they can present very differently. So it's important to not generalize based on a few people that you've known who are on the autism spectrum or things you've read. I think healthcare providers can learn a lot, as we all can, from children and individuals on the autism spectrum. They can just be the most fascinating, wonderful people, and they can really help all of us think out of the box.
Best practice number 8, make good transitions. Transitioning youth with disabilities into an adult-focused healthcare setting can be challenging. Planning ahead and involving the caregiver and the patient create a smoother transition and build increased independence for youth in managing their own health care.
Our transition to adult care actually went so much better than I thought. I mentioned our beloved pediatrician. He actually helped me facilitate that. He emailed me to let me know that he was retiring, and then mentioned that he would like Aaron to be the last patient he saw on the day he retired. And we actually scheduled an hour-and-a-half appointment. He made some suggestions to me as some possible doctors that it might make sense to transition Aaron's care to. I had time to interview those doctors. I made the decision who the doctor was going to be. We invited that doctor to the appointment, and we spent an hour-and-a-half talking about Aaron's care and the things that have worked with him, the things that didn't. I thought it was really wonderful that she had a chance to observe how Dr. Bartlett interacted with him.
And as far as my role as an advocate for my daughter, now that she's 15, I look back and I see how much it's changed and how much it really has been a journey. When she was younger, I was the case manager, and I was the one doing all the research, looking into different therapies, talking to doctors, also talking to teachers, and really working hard to help with her services. Now that she's older, I have to step back and let her take the reins more and be her own advocate. And she can do it. She's able now to tell doctors how she's feeling and really try to explain how she's feeling as best she can.
Best practice number 9, keep hope alive. Health providers cannot always predict how a child will respond to treatment or how the child's development will progress. When a child is given a negative prognosis, it is still important to never give up on the child, to continue to explore treatment options based on new research, and to keep hope alive for families.
We were basically told that she would live weeks or months because of the severity of her disease. So we took her home and loved her, as they told us to do, sent us home with absolutely nothing. We started researching what we could do to give her the best outcome possible. And the thing we kept finding was just that there was absolutely no hope and nobody was really willing to try much, even though through our research, we had found that there was actually a lot we could do for her. So we eventually landed on the University of Iowa hospitals and found a pulmonary team that was willing to look at the research we had found and said, yep, let's absolutely do it. And that was the first glimmer of hope that we actually had for our child, so that we could actually give her a chance at life and best quality of life possible. At a previous institution, we had requested certain equipment for our daughter that we had researched and found would help her. And that physician in particular just said, I'm sorry, that will never work for her. Not having tried it, he just simply said he didn't believe it would work for her. And I said, what's the harm in trying? Stella is actually now 8 years old. She's far outlived her prognosis of weeks or months, obviously, and she's like any other kid any other little girl that likes purple and pink and Taylor Swift. I think one of the important things in dealing with parents and children of special needs is that even if it's a doom and gloom type of situation, the outcome is most likely going to be a poor outcome. That you don't always have to completely give up hope on that child until there are no options. It's really important to that parent who hasn't given up hope to see that you are trying to do the best for that child and are willing to do whatever possible to make sure that that child gets treatment.
Let's review these best practices for providing health care to children and youth with disabilities. Number 1, help parents not feel overwhelmed. Number 2, it takes a village because care coordination is so important. Number 3, communication is key. Number 4, all in the family, because listening to family members is critical for providing good care. Number 5, get real. Make sure you consider the impact of treatment on daily life. Number 6, cope with anxiety. Number 7, respond to special needs because each child is unique. Number 8, make good transitions to adult health care. And number 9, keep hope alive. We hope that these parents have given you deeper insight into the perspectives of families who access health care for children with disabilities or special health care needs. We also hope that you have learned practical strategies for providing high-quality care to these children and for supporting their parents and caregivers. As healthcare professionals, you are in a perfect position to make positive changes in the lives of children with disabilities and their families.